Hello, thank you for joining us for this Mission Cure webinar. We will be starting in about 3 minutes.
All right, can you hear me?
We can hear you, and Dr. Penn, we're also live now, so we have quite a few attendees, but we're going to give them another 2 minutes for everybody to get on the line.
Okay.
Hello, thank you for joining us for Mission Cure's webinar. We will be starting in about 1 minute. We're going to give people just another minute or so to log on. Okay. Hello, everybody. Good morning, good afternoon, good evening, depending on where you are. I am Megan Golden. I'm co-founder of Mission Cure, and I will MC this webinar. I'm here with my colleagues, Avi Kohler and Sophia Garcia, and also Linda Martin, my co-director and now board chair. And this is the first Mission Cure webinar of 2021 for patients and families on pancreatitis. There are over 320 people registered, which is a record for us. We're very excited. And we're also live streaming on Facebook for the first time. So before I start, I just want to let you know that the webinar is being recorded and it will be posted on our website and emailed out to everyone who registered by tomorrow. You are all in listen-only mode, meaning that we can't hear you, but we do want your questions. Please type them into the Q&A box on your webinar control panel. It should be, at least for me, it's on the bottom of my Zoom screen. We've set aside plenty of time at the end of this for Dr. Penn to answer your questions. So next slide, please. Here's the agenda. I'm not going to read it to you, but I just will say that we're lucky to have a person who has suffered from chronic pancreatitis, Melissa Moots, share her story, and then also a really top-rate physician and medical school professor, Dr. Penn. Next slide, please. My brother Eric and I, who you see in the picture, co-founded Mission Cure a little more than 3 years ago after he was diagnosed with chronic pancreatitis. And it did take several years and several misdiagnoses for him to get that proper diagnosis. And when we learned that there were no approved treatments to stop or reverse the disease, we set a goal of finding effective treatments within 10 years. And we were almost immediately thereafter joined by Linda Martin who had been through a similar process with her daughter, Amy, and they are both, I believe, on this call. And so we're together working hard to develop treatments and improve the care of people with pancreatitis. So next slide, our patient education program is part of that effort. We thank AbbVie for supporting our patient education program, including our webinar series. And we chose diagnosis because almost every day we hear from patients who have frustrations or questions about diagnosis. So I actually want to start with a little poll. Hopefully that popped up on your Zoom screen. How long did it take you to get an accurate diagnosis? Less than 1 year, 1 to 3 years, 4 to 6 years, 7 or more years? I still don't have a diagnosis that explains my symptoms. And I see that and this is obviously if you're a patient or a caregiver of a patient. I'll just give it a second for the results to come in. And then I'm going to introduce Melissa to share her story. Okay, let's end the poll and I'm going to share the results. All right, well, it looks like we're about neck and neck with I still don't have a diagnosis and less than 1 year. And significantly, we have 12% of people who had 7 or more years to diagnosis. So the answers to this poll are exactly why we are doing this webinar. So next slide, please. I would actually like to now introduce Melissa. And Melissa, thank you for being here and sharing your story.
Hi, Megan. Thank you for having me. My name is Melissa Moots. I am a stay-at-home mom to a 3-year-old little boy and a 4-month-old baby girl. I am also a wife to a college football coach here in New Orleans, Louisiana. I am a chronic pancreatitis survivor and a TPATE recipient from Dr. Catherine Morgan at MUSC. My chronic pancreatitis journey started before I was even born, as my mother had chronic pancreatitis. She unfortunately passed away from complications to the disease at age 35, and I had just turned 6 years old. From that point, I went to foster care, and I remember many times being in the floor of my bedroom screaming out in pain, but unfortunately I was not taken to the hospital. So it wasn't until I was 16 years old that I first went to the hospital. And I remember the doctor coming in, and the first thing he asked me was, how much have you had to drink? And at this point, I was 16 years old. I had never had anything to drink, never smoked, really had no reason for having the disease. For the next 15 years, my story kind of went like that. I found a regular GI doctor, but he really seemed to just not believe me. He would tell me I had IBS due to PTSD of childhood trauma. I just wanted drugs, or I was in a stressful situation that I just wanted to get out of. So I never really got the chronic pancreatitis diagnosis until I had gone to the hospital 3 times back to back. It was within a week. And my doctor kept sending me home saying, you know, it was all in my head. I was just fine. And then one day I could not make it to the hospital anymore. So I had to call the ambulance. They took me to the local hospital in town, which was just a smaller hospital. And thankfully the ER doctor admitted me and gave me some medicine to take care of the pain, and told me the GI doctor on call would meet me in my room when I got there. And thankfully for me, the GI doctor on call was Dr. Penn, and that, you know, began our patient-doctor relationship, which I am so thankful for Dr. Penn. And I'll never forget that day, because he said 3 of the biggest words that I had longed to hear for so long. And he and his assistant came into the room, and I think he could see the desperation in my eyes. And I was thinking, okay, you know, here we go again. I'm going to have to plead my case. And he just simply said, I believe you, and we're going to find a plan for your care. And so that is how I was first introduced to Dr. Penn.
Thank you, Melissa, for sharing that. And we'll actually have a chance in a little bit to ask you and Dr. Penn some questions about that. So now I am honored to introduce Dr. Eli Penn. He's an associate professor of medicine at Mercer University in Georgia, and also a GI, a gastroenterologist at Atrium Navicent Health System. He's been practicing for nearly a decade and has a reputation, as you've heard, for dedication to his patients. And his expertise is in endoscopic management of chronic pancreatitis, GERD, gastroparesis, and inflammatory bowel disease. So welcome, Dr. Penn, and I'm turning it over to you.
Thank you, Megan, and thanks for allowing me to speak. Melissa, it's so good to see you, and it's really been fulfilling to see your progress over the last few years, and it sort of validates what I like to do, and that's to sort of free the patients like you from the stigma they face in ERs and doctors' offices across the land. Chronic pancreatitis, I became interested in pancreatitis in general when I learned endoscopic ultrasound, which we'll talk about, but as a modality, it is probably the most sensitive for detecting this disease when other tests fail. I will say that there are unfortunately many patients like Ms. Moots who have a similar story, years of sort of doubts and skepticism from the medical community, even highly trained physicians who just are not familiar with how chronic pancreatitis presents and the real frequency in our population. So there are two main types of pancreatitis, and they're very different in that acute pancreatitis has an undoubtable presentation with gross lab abnormalities and CAT scan findings. It's actually a very dangerous event with a 5% mortality rate or chance of dying with each episode. So it's well recognized and sort of one of the first things that medical students learn about. On the other hand, chronic pancreatitis results from repeated insults to the pancreas, even if they're not fulminant. Just over the years, repeated episodes of inflammation can lead to scarring, which actually makes it very difficult to diagnose in many cases because the pancreas can no longer generate enough enzymes to have them elevated on labs, and inflammation is not well seen on CAT scan. So it's much more common than is recognized. But I separate these two entities because they're so different in the way we diagnose them and sort of manage them. So to talk about how we arrive at the diagnosis, as I said, acute pancreatitis, fairly easy. A first episode of severe abdominal pain should conjure in any physician's mind the possibility of pancreatitis, and labs are immediately confirmatory. But really the talk today is about the roadmap for diagnosing chronic pancreatitis, which is much more challenging. So there's two main questions that the audience probably wants to know when it comes to the diagnosis. Number one, if the pancreas is inflamed, how do we go about demonstrating that? And then number two, which is important for patient and physician, what's causing the inflammation? Because without identifying a cause, there's little hope of successful treatment. As far as getting a physician to recognize your symptoms and consider the diagnosis of chronic pancreatitis, that is the most crucial step, is just to have that on their mental list of possible explanations for your symptoms. So we call that the differential diagnosis. So if it's not in their first list of possible explanations, then the likelihood that they're going to treat you appropriately and make the diagnosis is very low. Once you find a physician who is willing to consider that and order the proper tests and get the diagnosis, it's very, very important to have it documented in your medical record. Because as Ms. Mooch experienced, she had been in multiple hospitals, multiple physicians. Very, very important that the portable record will show that the diagnosis has been made. Makes it much harder for people to sort of question it. So what should a doctor look at when a patient with chronic pancreatitis comes to be evaluated? And the main things are a patient's symptoms. So they're very characteristic. And although there's some similarities to other problems in that area, like peptic ulcer disease, gastric motility disorders, there are some unique features that should sort of trigger their minds to think about the pancreas. Blood tests and imaging should always be considered, and likely not the standard tests, not the same tests that show acute pancreatitis, for example. And then a patient's personal and family history must be considered, not just the immediate episode, and certainly family history of pancreatic disease. So when we talk about symptoms, one of the unique things to pancreatic pain is that it often radiates to the back. Maybe 50% of patients or more will describe a severe epigastric pain that radiates to the back. What a lot of physicians seem to sort of fail to recognize this day and age is that a good physical exam is very, very helpful in isolating pancreatic pain. There's a very particular spot between the umbilicus or belly button and the sternum where the head of the pancreas is, and deep pressure in that area will always elicit the severe abdominal pain that the patient complains of. So it's anatomically appropriate if a physical exam is done well and consistent between patients. Patients often will give you other clues if you only ask about them. And one of the best clues is malabsorption causing diarrhea or a change in bowel habits. So, for example, a military a soldier in the Army had come to see me after 6 years of unexplained sort of diarrhea and floating stools after he ate, inability to gain weight, and fatigue. And it turned out to be chronic pancreatitis. He'd had numerous scopes, all normal, numerous CT scans. But the big clue he told me right away was that his stools had started floating about 6 years earlier. And so that told me immediately that I should be considering pancreatic disease. And in his case, the epigastric pain was not the most prominent symptom, but it was there. And then fatigue itself can come from a lot of different sources. Anybody with a chronic inflammatory condition develops fatigue, but in chronic pancreatitis, the extra component is fat-soluble vitamin deficiency because the pancreatic enzymes are particularly important for digestion and absorption of fat, and vitamins A, D, E, and K. Vitamin D deficiency in particular is often striking in patients with chronic pancreatitis. And then imaging. So unfortunately, we've come to a place in medicine in America where we rely very, very heavily on CT scans. And worse than that, we rely on somebody else's interpretation of our CT scans. So when I talk to medical students, I encourage them to look at every single scan themselves because they know that the history and the symptoms the patient's complaining of. And CTs have been held on a pedestal because they're such a staple of American medicine. But when it comes to the pancreas, they're just not very good at detecting disease. And that includes early cancer. and that includes certainly chronic pancreatitis. Statistically, chronic pancreatitis only shows up on about 10% of patients on a CT scan. And those are the patients who are fortunate enough, I should say, to have stones large enough to be seen on CAT scan. Otherwise, it's almost impossible to tell the difference between a perfectly healthy pancreas and someone like Miss Mooch. And she can testify, she probably had many, many CT scans in her time. There are certainly other tests, MRI in an expert center with a very good radiologist can often see features that won't show up on CT scan. But perhaps the best test is one that I do. It's invasive in that it's an endoscopy, but endoscopic ultrasound, where we place the ultrasound probe right up against the wall of the stomach where the pancreas is. We can see incredible detail that includes features of fibrosis that are only seen on this type of this test. And it can give you a very early clue for the diagnosis of chronic pancreatitis. This is an example picture from an endoscopic ultrasound. And I know it looks like static to most, but if you look at the encircled area, that's pancreas. And what you can see is bright white lines, dark spots, almost black dots. The black is because there's no functional tissue left. It's dead pancreas. The bright white lines represent calcification. And then the big dark vessel, or I'm sorry, not vessel, duct below this circle is the pancreatic duct, and it's also lined with calcium. So these and other features constitute what's called the Rosemont criteria for chronic pancreatitis. And although they're not perfect, and somebody with the proper symptoms and these findings, you can bet that it's chronic pancreatitis and the patient should be managed accordingly. So they're in places that don't have endoscopic ultrasound, or where EUS is not something you can have on the day that you present. It's important for physicians and patients to know about inflammatory markers. So inflammatory markers are, I call them dummy markers, because they don't tell us where the problem is. A dental abscess will cause them to go up. A UTI will cause them to go up. But in somebody who has none of those things and comes in with severe abdominal pain, and it's at a normal endoscopy, when the C-reactive protein and sed rate are through the roof, we're sort of forced as your physician to explain them. It's not, just because your lipase and amylase, the standard pancreatic tests, are normal, does not mean there's not massive pancreatic inflammation. So it's important for me to think about that, but it's also important for patients to know about it, so they can ask what their inflammatory markers are. I often will track the CRP rates, for example, in somebody admitted with chronic pancreatitis, to make sure they get down below 10 before they're able to go home. And I saw someone the other day with a CRP of 95, chronic pancreatitis, but normal lipase and amylase. So that tells you that they are a good way to find that something is going on, although they don't specify it's the pancreas. Other tests can give you clues to the cause of chronic pancreatitis, or acute pancreatitis for that matter. Elevated triglycerides hint at familial hypertriglyceridemia, which is actually pretty common. And if the numbers stay above 500, the patient will get pancreatitis over and over, and it can be fatal. It's a very serious form, but it's very treatable. So it's important that people have a workup for the cause of pancreatitis. Bilirubin being elevated suggests gallstone disease due to blockage of the bile ducts, and then consistently elevated glucose suggests that diabetes can be playing a role, and there are others. When chronic pancreatitis is advanced enough, you can detect functional problems, meaning that the pancreas is not actually carrying out its functions as a healthy pancreas would. And those include testing fat-soluble vitamin levels like A, D, E, and K to look for evidence of chronic malabsorption of fat. Perhaps the best test to ask your doctor for if you think you have chronic pancreatitis and are undiagnosed is the fecal elastase. It's a stool test, but when the elastase is low, it means that the pancreas is not producing enough enzymes to digest fat. And that only happens after about 90% of the pancreas has been damaged. So it is very sensitive and specific for pancreatic insufficiency. It probably, I probably should have put this first, but in a patient like Ms. Moots, who's had a strong family history of pancreatic disease and repeated episodes of epigastric pain, worse and worse throughout the years, that is so important in narrowing down the diagnosis. I would hope that physicians would ask about more than the last week or two, that they would ask about their childhood and the progression of symptoms, because the pattern is very characteristic. It may not be as common as peptic ulcer, but usually by the time I see these patients, they've already had things like that ruled out. And the family history of pancreatic cancer is also strongly suggestive of a genetic predisposition to pancreatitis. There are known rheumatologic diseases and autoimmune disease associated with pancreatitis. That's also a part of a good history. And then other syndromes other than autoimmune that can be associated with both chronic pancreatitis and pancreatic cancer. So in broad strokes, the causes of pancreatitis are numerous. Genetic causes are sort of being ironed out better and better every year. We learn about new genes that likely contribute to early onset pancreatitis. Biliary causes, meaning obstruction of the bile duct, and vicarious obstruction of the pancreatic duct. That's probably the #1 cause of acute pancreatitis in the United States. But it also can lead to chronic pancreatitis in patients who have gallstones but have never had a cholecystitis attack, a gallbladder attack, so to speak, can chronically drop sludge and stones through that bile duct and cause low-grade obstruction of the pancreatic duct and pancreatitis. And then metabolic factors, which I would throw in toxins as frequent culprits, medications, and then finally autoimmune conditions, which are more common than we used to think, but there's actually several forms of autoimmune pancreatitis itself that are fairly easily treated if only recognized. So to break these down a bit, the known genetics, the probably best known right now are 3 mutations: the PRSS1 mutation, which is inherited in an autosomal dominant fashion, which means there's every generation of a family is affected. The cystic fibrosis transmembrane regulator, CFTR mutation, extremely common in Caucasian folks. It's a large gene, so not everybody who has the mutations on that gene get cystic fibrosis, far from it. Most patients probably get chronic pancreatitis and may have some degree of chronic lung disease, but that's a commonly found mutation. And then SPINK1. But there are newer genes to be tested every year. In fact, a new one came out this year. And then there's some more complex gene mutations that are sort of imply concurrent risk. Biliary causes of pancreatitis are the most common, as I said. And this is just a little depiction of how that works. You can see the stones in the bottom of this green duct coming from the pancreas. That's the bile duct. And if those gallstones that leave the gallbladder are large enough, they temporarily obstruct the exit of the pancreas into the bowel. And that also obstructs the pancreatic duct from releasing its enzymes. The enzymes then become prematurely activated and auto-digest the pancreas. And that can happen over and over, leading to chronic pancreatitis, or it can happen acutely, leading to acute pancreatitis. So when it comes to autoimmune pancreatitis, probably the most obvious finding in these patients is they obstruct. The pancreas tends to swell. It's often mistaken for a cancer. It's mostly men for some reason, but they will get obstruction of their stomach, intense nausea and vomiting, and it'll appear mass-like. We tend to initially treat them with steroids, and it just melts away. The tumor that the radiologist saw just melts away while they're in the hospital. So it's pretty phenomenal. And we use long-term immunosuppression to manage them. I actually saw a young man this week with this, and he's just beyond college age, so he drinks a fair amount, but that was not the cause of his pancreatitis. And the doctors he had seen in previous town I practiced in just couldn't get around the alcohol part, even though it was clearly autoimmune. So it illustrates the difficulty we have still with the 50-year-old conception of alcohol being the cause of all pancreatitis. Metabolic factors include hypertriglyceridemia, I mentioned, which is easily treated once diagnosed, and a related sort of cholesterol or problem, familial chylomicronemia. The toxins, it's important to know that the number one cause of chronic pancreatitis, or the number one association in the United States, is tobacco smoking. And I put much greater than alcohol. So that's very, very true. We used to think, again, 50 years ago, that alcohol was the culprit in almost all cases, and it's just not true. Medications, particularly the new diabetes medicines that mimic insulin, are common culprits. We probably see a patient a month in the hospital who develops pancreatitis from one of the glipidin drugs, and hypercalcemia, but other toxins exist. Again, the most common is tobacco smoking, and then some of these diabetes medicines. So what I was hoping to convey today, and why I'm so glad to give this talk, is some takeaway points that will help the listeners to engage their physicians in a way that will sort of force them to consider the diagnosis and then make the diagnosis so patients can get what they need sooner. So number one, a good physical exam can be very suggestive of pancreatic disease. And I would take that to the extent of, grasping your physician's hand and putting it where your pain is and asking them what's there. And you really have to, physicians are certainly busy, but you have to stop them and make them pause and answer your questions. Ask about inflammatory markers. If they weren't checked, would you check them to see if something's going on? They can be very, very helpful, and maybe the only clue that you're having a flare of chronic pancreatitis. Endoscopic ultrasound, a very important part of the workup, because detection of the Rosemont criteria can sometimes be the only evidence of disease if you don't yet have the pancreatic enzyme deficiency. It also affords the endoscopist to perform a celiac plexus block, which can greatly relieve the pain for 6 months or longer. I found that to be very useful. Doctors should conduct a thorough investigation of the causes, not just assuming that however much alcohol is consumed is the culprit. And unfortunately, that's still a relic from old medicine. And we should know better now that there are much more common causes.
Great. Thanks, Dr. Penn, for walking us through what a comprehensive diagnosis process looks like. Hello, everyone. My name is Avi, and I lead patient-centered care efforts at Mission Cure. As Megan mentioned at the outset, we will be taking questions from the audience, and I see a few coming in already, so please feel free to type them in the Q&A section in your webinar window, and we'll be getting to it in just a few minutes. And to kick off the Q&A, I just wanted to start with a couple of questions for Melissa and Dr. Penn. As we just heard from Dr. Penn, pancreatitis is a complex disease, and it requires problem solving and comprehensive look at various factors to arrive at that diagnosis. But we also believe that shared decision making between the provider and the patient is important to arrive at the diagnosis and also a care plan from there. And so I just want to take a couple of minutes to hone in on that trust and relationship piece between the patient and the doctor. And so, Melissa, if I may start with you, and you started to talk about that as you shared early on, but you said you had consulted with several doctors, had gone to the ER a few times before that ER visit where Dr. Penn walked in and said, I believe you. Can you share with us a little bit about how Dr. Penn was different from the other doctors that you had seen, and what about his approach made you trust him?
Sure. So I think the first thing that really drew me to want to have Dr. Penn as my primary provider was that he believed me. I had never heard those words prior, whether it be with doctors, with nurses. Nobody really seemed to understand that there was a reason for this pain, that it wasn't just in my head. And so Dr. Penn, he didn't just speak at me. He really seemed to listen to me, to ask me, where the pain was, what was going on. He didn't just spit out some jargon, push on my stomach and tell me it was in my head. He also showed up. And so by that, I mean, he didn't just show up at the hospital to tell me I'm going home. He would make sure if I was in pain, he was available to his patients. You didn't have to worry about not being able to get in to see him. If you were in pain, he was going to find a plan and make sure that he could set you up for a plan of care to where you were taken care of and you weren't just left in misery. And so that really just spoke a lot to me, that he would go as far to believe me, even though every scan showed, she's not having a pancreatic flare. And he just did what he could to take care of me and show up when other providers would tell him it's all in her head. He'd say, no, she's sick and we're going to find out why.
Yeah, thank you. And, one thing, Melissa, that you mentioned when we chatted earlier this week was he did not just tell me what I am feeling based on what the test results are showing. He's asking me. And I think that says a lot about combining different factors to arrive at a diagnosis. Dr. Penn, if I may ask you a similar question, from your perspective, how can a patient prepare and show up to help establish and set the stage for that trusting relationship? What do you need from a provider standpoint?
So a patient who's informed about the tests that he or she has had in the past that have not been fruitful is very helpful to me. When a patient in particular says, I've had 3 endoscopies by Dr. X, and they saw some gastritis, but that's it. Even when I was hurting terribly and my CT scans were negative, that immediately raises my suspicion, because there's only a few things that patients with severe pain in that area can have that would have been missed on those 2 tests. And one of them is chronic pancreatitis. So a good history, self-history, about the test that she's had in the past is very helpful and shows engagement in wanting to find an answer. So that certainly helps.
Great. And then just, I know we have more questions coming up from the audience, so I want to open up for that. But Dr. Penn, one last question to you, at least from me, is as the webinar today, and we as Mission Care will continue to share more resources with our patient community in the near future to navigate not only the diagnosis, but also the management process. What is your advice to patients in how they can use these resources to tactfully advocate with the providers? We know that's not always a very comfortable conversation. So what would be your advice to our patients?
Well, not giving up, not taking no for an answer, and not, I think that it takes a lot of persistence, unfortunately. We can't change the nation's healthcare system and physicians' likelihood of recognizing this disease immediately. But over time and with numbers, we can bring it to their attention. So forcing a physician to engage in a talk about possible explanations for unexplained pain. That's something that there's a built-in disincentive in American medicine to do. It's not time efficient, it's not lucrative or productive. There's so much pressure now to do as many possible procedures as you can and see as many patients as you can, and to actually stop and think like a medical student, and consider things that you haven't thought about or are not familiar with. And it takes some prodding. So, a reasonable patient who's suffering unreasonable pain should accomplish that if you direct your physician and ask them about these tests we mentioned, like the inflammatory markers, the EUS. If you grab their hand and show them where you're hurting and tell them it radiates to your back, if it does, and about the tests that you've had that showed nothing. I've had some really good gastroenterologists around the Southeast tell people that they were just overly sensitive to pain or had IBS. And that's altogether inconsistent with the symptoms that people with chronic pancreatitis feel. And so it would be fairly easy, I would think, to call them out on that, and to ask the physician, does IBS hurt so bad that you can't move and can't breathe? There's ways to ask those questions without implicating them and making them feel like they're failing you. But that's kind of what's going to happen if you don't engage them.
Well, yes. No, thank you. This is super helpful. I want to turn it over to Megan now. Megan, are you with all the questions we have coming in?
Yes, we have a lot of questions. Actually, Linda is going to take the questions. I have a couple that came in advance, but let's let Linda get started.
Okay, we have Dr. Penn. They're coming in fast and furious. I will try to group a few of them together, but just to try to get to as many as possible, they're going to be all over the board. So we'll jump from sort of one topic to another, but let you answer. So one of the attendees asked the question, what is the likelihood that their acute pancreatitis was preceded by years of chronic pancreatitis, but that had been undiagnosed, in addition to ongoing CP since his AP attack, so trying to figure out, although he was diagnosed with acute pancreatitis, could he have had chronic pancreatitis for years in advance and just been undiagnosed?
It's possible. It's usually the other way around. So usually recurrent acute pancreatitis leads to chronic pancreatitis. However, there are lots of people with chronic pancreatitis who have not had an acute episode that landed them in the hospital. They may have had unexplained pains, but small amounts of injury on a daily basis over years can do the same amount of permanent damage as 5 severe attacks and nothing in between. So it's not necessarily the case that acute pancreatitis is before chronic pancreatitis, but that's usually what happens. And many patients who have the symptoms of chronic pancreatitis or have had enough attacks of acute will be found to have chronic. So chronic is fairly easy to develop after even a few bouts of acute.
Great, thank you. And then there's a few questions around basically nutrition and PERT. So first of all, one question is about how, in your experience, patients with CP are able to gain weight. And I'm going to give you the other couple as well. And then in terms of your experience relative to enzymes, do you find a difference in your patients in the way that the different brands like Creon versus Viocase work? And then from one attendee who wanted to know, if you can't afford the prescription enzymes, are there any over-the-counter options that you found to work for patients?
So all good questions. Almost everybody who needs enzymes will gain weight on enzymes as long as they're on the appropriate dose. And unfortunately, that's been another problem. The pancreas, basically every time you eat a meal, secretes about 900,000 lipase units. And you only need 10% of that to have adequate fat absorption. That's 90,000. Unfortunately, the standard dose for pancreatic enzyme replacement is about 10,000 per meal. So it doesn't work. And people quickly stop it or stop paying for it, certainly, because they don't notice any benefit. The appropriate dose is a minimum of 72,000 lipase units per meal. And on that dose, people will gain weight. Their bowels will normalize. And some of them will have reduction in their pain over time because it decreases the stimulation of the pancreas after meals. Although that's less patients than we would like. As far as the brand doesn't necessarily matter, the commercial brand that is. But I will say that my experience with Creon has been very favorable, mainly because the patients who can't afford them, I've never had a patient not get what they needed. They have a very aggressive patient assistance program. So I've been very pleased with that. As far as the over-the-counters, it's kind of a big wild card. If they contain what they say they will, and you can calculate out the 72,000 lipase units per meal, then they should work theoretically. The problem is, and I don't have any personal experience to say this is valid, but they don't always contain what they say they do. And when I looked at an enzyme recently that a patient brought in, I think there was 1,000 or 2,000 lipase units per pill. So they would have had to take 72 pills with each meal. So that quickly would become very expensive.
Yeah, right. And just to add to that, the over-the-counter enzymes are like other supplements, not FDA approved or controlled. And so just to affirm what you just said, it's a wild, wild west out there. So people have to be cautious of not being sure what you're actually getting. Okay, so shifting gears a little bit, several questions around sort of the staging of chronic pancreatitis. One patient said that her GI said she's in the early stage and therefore there's nothing to be done but wait. And then several questions related to whether chronic pancreatitis is reversible, whether you've seen anyone improve who had been diagnosed with chronic pancreatitis, and sort of what is the prognosis?
So it varies depending on the cause, the prognosis, and so does the treatment strategy. So when we first identify pancreatic disease, whether acute or chronic, it's a mad rush to find a reversible, treatable cause to prevent further damage and to prevent an episode, an attack, which again can occasionally be fatal. Once all potential causes are ruled out, and you don't have a cause, including genetics, then we usually assume that it's genetic. But again, that's a very thorough investigation. I think someone had a question about gallstones in the gallbladder, recurrent pancreatitis. Those patients need their gallbladder taken out. if you can't find a reason and they have a gallbladder full of stones or sludge, it needs to come out because it's not worth the risk of recurring pancreatic damage. If it's genetic or presumed genetic, then there's really not yet, there's not a lot of treatment. And the prognosis varies depending on what genes involved in the particular patient. So you do have to watch and see how things evolve over a period of time to decide, ultimately what the plan is going to be. So in the absence of an identifiable, modifiable cause, and given that the patient's not a smoker or has quit on your advice, there's really there's no way to stop the progression of disease because presumably the inflammation is ongoing. I have seen patients, particularly the smokers, when I tell them about their risk for pancreatic cancer being about tenfold, it seems to make a big impact, more so than the risk of lung cancer for some reason. But they quit, and within a year or so, a lot of them will have improvement in their pain scores. I have not seen anybody stop needing enzymes. So once EPI develops or pancreatic insufficiency, it's likely a lifelong requirement to supplement with enzymes, which, all things considered is not a big issue as long as it's covered, and as long as it's affordable. As far as reversibility, so not yet. We don't have anything to reverse scarring of the pancreas. I often get that question from liver patients about the conception that the liver regenerates, but not when there's scar tissue. It can't be replaced. Now, in the future, we're looking at stem cells, all sorts of exciting interventions that may help with that. But as it is now, the people who are diagnosed with chronic panc are pretty much going to stay where they are or slowly progress.
And we invite everyone to stay tuned to Mission Cure, who is working very hard to find those treatments and eventually cures for this terrible disease. So stay tuned, and we'll follow up with the folks that ask specific questions with more information about that. I think there's some just sort of, I would call them individual but interesting questions. Are there any studies that you're aware of that have indicated that cannabis use or vaping can cause CP?
I'm not aware of them, but the compounds in cigarette smoke that are implicated in CP it's not nicotine, so it is smoke. So I would assume that anything you burn and inhale, any carbon-based substance, which is pretty much everything you would smoke, could cause chronic pancreatitis. So but that's not it's not proven. But even a firefighter, I would think, would be at increased risk.
Right. That's interesting. How about pancreatitis? What do you think about that in terms of a cause?
It's definitely a co-cause. It increases your risk for acute pancreatitis and therefore chronic pancreatitis, but it's thought that there has to be a second factor. And so, but that's probably true about a lot of people with chronic pancreatitis. So this young man I was alluding to who came in with autoimmune and been labeled as alcohol induced. He wasn't a particularly heavy drinker, but in his case, his pancreas may not have tolerated any alcohol. Or you could say that another way, his alcohol consumption was not compatible with his autoimmune disease. So there's probably, genetic basis for a lot of people who develop early chronic pancreatitis, and there are probably cofactors involved.
Right. Okay, I'm going to just jump a couple more questions. Switching to your expertise as an endoscopist, can you discuss false positives in EUS and changes that could be related to age instead rather than CP?
Absolutely. So, and there is some controversy about the Rosemont criteria I described, because depending on when they do biopsy studies, we'll take a small biopsy of the pancreas and compare the degree of fibrosis with the Rosemont criteria. When we set the amount of fibrosis to a high degree, then the Rosemont criteria are strongly predictive. But as we lower the amount of fibrosis in the study that we're comparing with the Rosemont criteria, it becomes less predictive. So that's been used to debate the validity of Rosemont criteria. And in fact, I've shared patients with EUS docs around the Southeast, some who have said the same patient who had Rosemont criteria had a normal pancreas, and would not give an explanation for the pain or the EPI. So clear cases of chronic pain that I could see on EUS, but another endoscopographer disagreed. And these are prominent docs. And I'm sure it's gone the other way. Now, the pancreas is what I call a wear and tear organ. It ages and develops scar tissue in every single human being. And you know, when you become 70 years old, even if you've never had a pancreas problem, the chances are you will have some features of the Rosemont criteria. But the chances of you having every feature and epigastric pain that radiates to your back and a normal endoscopy and a negative gastric emptying study are almost zero. So I think we're missing the big picture as gastroenterologists. We're not advocating that everybody in the country have an EUS. And we're not advocating that, I'm not advocating that Rosemont criteria be the sole determinant of chronic pancreatitis. But to use some common sense, when there's no other cause of what is severe abdominal pain by the patient's account, not our account, Rosemont criteria becomes strongly predictive. What we call pretest probability is high. And then it's a very, very useful test. So there was a question about, I think about EUS and how important it was. It honestly depends on the gastroenterologist's perspective, because there are there's certainly some who would say they would not rely on those criteria to make the diagnosis, and to a fault. So even in patients with obvious signs, symptoms, and lab abnormalities consistent with chronic pancreatitis. So it is, it's not in the eye of the beholder, but the interpretation of these Rosemont criteria really depends on the gastroenterologist. But I've found many a patient with chronic pancreatitis in that way when other tests were negative. And in Ms. Moot's case, if you don't mind me sharing, Melissa, even some very good gastroenterologists in our area thought nothing was wrong with her pancreas, including, I think, the center where she ended up having her surgery. Yet when we did her surgery on one of her best pain days in a long time, the pancreas was completely destroyed and bleeding spontaneously. And that's something we just don't have a good imaging test for. EUS may be the best.
Yeah. I'm gonna just ask you one final question, because we're just about out of time here, and I know Sophia needs to wrap up. We have many questions, and you could take a long time to answer it. So in 30 seconds, so many people want to know, how do they find a pancreas specialist that will take them seriously and listen to them and believe them? They can all line up for you, Dr. Penn, but if they live across the country, do you have any advice for finding sort of a caring GI?
I wish that I did. I think that anyone who sort of claims to that to be their interest or specialty is likely to be a good pick. Like me, I tend to gravitate toward people with unexplained severe symptoms who have not gotten the care they needed, and that's guided my career and the choice of diseases that I'm interested in. So I know there are others like that, but maybe check out the sort of the bios online of the gastroenterologists who are interested in chronic pancreatitis. That's probably the
And
place.
I should add that Mission Cure is working with one of the Facebook groups to compile a list of pancreas specialists who have been recommended by other patients. So we will make that available to you.
Great.
And I think we still have a lot of unanswered questions, and we will do our best to consult with Dr. Penn after the webinar and either get back to people individually or maybe post some Q&A on our website. So, Sophia?
Yes, thank you everyone for joining us on our first webinar of 2021. We have many other informative and educational resources coming down the pipeline. They're all part of our patient education program, so you can feel free to stay in contact via social media. We are on Twitter at mission_cure and Twitter in the same handle, and at Facebook at Mission Cure CP. I'd like to quickly thank Dr. Penn for sharing his expertise with us, and Melissa for sharing her very touching story. We would also like to ask you to please fill out the survey after you leave the webinar. It's very brief. It'll just take a couple minutes. It'll automatically pop up on your browser after you exit this meeting. And as far as logistics go, I know a lot of you have been asking. You'll be receiving a recording of this webinar in full, as well as the slides that accompanied it. And you will also be receiving a printable patient toolkit that you can actually bring with you to your next doctor's visit. And it will have all of the information that we discussed today. And if you have any other questions, our virtual door is always open, and you can feel free to reach out to us. We're at mission-cure.org. Please do reach out. And thank you everyone, and have a great rest of your day or night, depending on where you are.